you are looking at prostate cancer here, localized prostate cancer. You're treating with curative intent. You've got a phase 3 study. What were you trying to do?
What we were trying to establish was whether we could exploit the radiobiology of prostate cancer, which may be particularly sensitive to fraction size, and to change the standard curative radiotherapy treatment from a 7.5-week treatment into a shorter 4-week treatment.
Right, so you've been doing hypofractionated radiotherapy. What exactly did you do?
Well, we compared the standard treatment using 2 gray doses per day with the larger dose of 3 gray per day, and we performed the largest randomized trial ever undertaken in localized prostate cancer, treating altogether over 3,100 men.
Right, and you've got 5-year results now. What were they?
The results showed that the shorter hyperfractionated treatments give similar efficacy when treated to a dose of 60 gray in 20 fractions, and this was non-inferior to the standard treatment. The other experimental arm, which was 57 gray in 19 fractions, so a slightly lower dose, we could not demonstrate was non-inferior. However, very importantly, the therapeutic ratio, that is the balance between efficacy and side effects, was good. In the trial as a whole, the side effect profile was very low because we used sophisticated, up-to-date radiotherapy techniques with scrupulous quality assurance. And so the side effect profile was actually half that in the preceding trial that was undertaken in the UK. So we're very, very pleased with those results for the whole trial, but specifically, we've shown that you can safely reduce the number of treatments from 37 to 20.
So although you're increasing the dose per fraction, which could risk more collateral damage, you're not seeing much?
We're not seeing that. We reduce the total dose to compensate for the bigger dose per fraction. It's like a little analogy, a boxer using a lot of big punches rather than a larger number of small punches.
So what potentially are the advantages for the patient?
Well, it reduces the number of hospital visits from 37 to 20. Big advantage. There's a big advantage for the patient. There are also issues of resource, because we can treat more patients with the same equipment. But I do want to stress again, we've only shown that this is effective and safe using high quality radiotherapy techniques. So that is part of the trial. And we use the trial as a vehicle for introducing these high quality techniques across the UK and in the centres in Ireland, Switzerland and New Zealand that took part as well.
Right, high quality is a big issue then. That means centres of excellence, presumably. What are the big pointers for doctors then to summarise?
We can do this, we can generalise this. We had 70 centres taking part. So this isn't just the specialised centres. Smaller centres can get up to the mark if they're given the assistance which this trial did give them. So the key point is that you can reduce the number of visits a patient has to make to hospital, and you can do that safely. That improves treatment for the patient and it saves resources at the same time. But high quality treatment is essential.
Thank you very much.